All right, we're going to look at some applications with computed tomography today. And first application, the one that is closest to my heart and research, is CT of the heart itself. You can see the remarkable resolution we get with CT scanning in a 3D object. These are often 256 slices thick and 512 by 512 in the XY plane. You can see tremendous details even in the secondary vessels. Say this is the right coronary artery here, and these are some small branches from that artery, and we can see details right down to the distal portion of the left anterior descending coronary artery. So this is obtained in one heartbeat in about 160 millisecond acquisition, and with a detector that is quite wide. So it obtains 16 centimeters in the Z direction simultaneously. And so this is pretty well transformed CT, such that it is now, in my opinion, the best imaging modality for cardiovascular imaging. This is some slices, axial slices of a CT scan through a heart, and you can see the extraordinary detail we get for the wall of the left atrium. These are valve leaflets in the aortic valve. That's a coronary artery. This is a coronary artery, and this is a 1/2 millimeter slice, and you get a stack of these representing the heart. These, excuse me, are oriented in the axial plane for this display. And you can see that there's an interesting noise pattern which radiates away, and it seems to be radiating from a source, and that source is down here. And it is the very bright signal from the aorta, which has blood with contrast in it right now. So it's attenuating a lot of X-rays and casting a fairly strong shadow, as is the spine, which is over here in the image. And because those objects absorb a lot of photons, the photon count number at the detector is quite small. And so you get uncertainty in that number and increased noise. And so you can see all along these lines, we have what seems to be a correlated higher noise, higher uncertainty. We can measure the root mean square deviation of this background if we're going to measure signal to noise. However, most of that variance comes from this pattern as opposed to some underlying Gaussian noise function. Is that an appropriate measure of noise? Well, probably for some applications, it's just fine. And in the left ventricular blood pool, we have a higher Hounsfield unit number. This is probably around 500. This is probably around 100 at this point. And again, you see that there's uncertainty in that. The noise in CT has this kind of snake-like appearance to it. It's quite correlated. It's not white noise on top of this image. With the convolution back projection algorithm, we're getting these long correlated noisy streaks. And however, again, the spatial resolution for these little small objects on the heart surface is quite impressive. If we zoom in on one of those coronary vessels, so this is the left main artery here. We can go back and I can show you what that is. This artery right here is called the left main, the one that goes from the root of the aorta out to the anterior descending coronary here. And this is the circumflex going around the back of the heart. This is the left main. And we're going to see in the next slice this split of these two vessels. And so here's the left main coming. We have dissected away the overlying tissue. So this is a curved path segmentation through the vessel itself. And you can see in doing that, in constructing that curved path, we have interpolated data from voxels in different places, and we've provided some kind of correlation, which looks like somebody took a paintbrush and kind of blurred it in this direction. However, so here's the left main coronary artery. If we look at A, this cross section is labeled A. That's up here, and it has a very nice wide open look to it. This is fat around the outside. Sorry, I went to the next slide here. So this dark signal is fat, this is blood, and this is blood in the coronary artery. The next slice that we'll sample, axial to the vessel, we have the left main, or right at the end of the left main, plus this lesion. And you can see the lesion basically looks like it is a bump on the coronary artery, and there's a bright signal here. And that bright signal is a little piece of calcium. It'd be quite small in order to make such a dim signal. But the orifice itself, the left main, looks okay. When we go down to the distal part where it branches to basically the left end here descending in the circumflex, we get this cross section. Now, if we go to the next slide, I'll bring in this C. We'll get right to this where the LAD branches off, and we can see that that vessel gets pretty small in diameter at that point. It's a lot smaller than it was, even 1 centimeter proximal to that. And so this is called a stenosis. It's not a hugely serious stenosis. It's about 50%, and you wouldn't do anything about this. You're not going to put a stent in here to widen this out. For one thing, you're right at a junction, which is a difficult place to put a stent accurately without messing things up. So, you can, in 3D, march through these vessels and look at their dimensions with great accuracy. And here's, what a case looks like in an axial plane, in the sagittal plane, and in the coronal plane through the heart. And you can see great details in this entire region from here, from this anterior portion all the way down to the inferior portion, is obtained in one acquisition. Right? This is the results from a high resolution scanner. And this, at the time that we took this data, this was an experimental scanner, came out of Toshiba. And what they did was they increased the number of detector elements on the X-ray detector by a factor of 2 in both directions, both in the Z direction and in the theta direction. And so the detector element itself is 1/4 the area of the standard sort of 1 by 1 millimeter detector you get in most CT scanners. And you can see the very high resolution details in the left anterior, or the left atrial appendage, I should say. You can see the actual details of the wall of the left atrium, really good resolution of the valve leaflets, tiny piece of calcium, very small piece of calcium on that valve leaflet, indicating this person should watch out in the future because they might develop a larger chunk of calcium and get some kind of aortic stenosis. So something to keep an eye on. And then when you go back to the root of the aorta, here's the left main, and there's that little tiny piece of calcium we saw in the previous scan. The previous scan was a standard scanner. This is the same patient, completely normal, asymptomatic person. And then as the LAD comes down here, you can see there's a tiny distal here, piece of calcium that is detected that probably went undetected with a lower resolution scan. And then as we cruise along, the LAD branches off, and the main branch has this piece of calcium in it as well. And so we're seeing very small pieces of calcium absolutely distinctly, that this is not going to be a false positive. You just can sense that from the signal to noise of this thing. And so it would allow earlier detection of coronary calcium, and that's for sure, this high resolution scanner. This is now in the field as a product, and people are not just using it for cardiac. In fact, it's difficult to use it for cardiac for a number of reasons, but they're using it for lung scanning and temporal bone scanning, things like that, for really high resolution applications. And it's just being determined, like, what are going to be the killer applications for this super high resolution device. This is one way of getting high resolution. The other way is to make a photon detector scanner, which virtually all of the manufacturers are starting to do now as well. And here's another piece of calcium in the right coronary. So beautiful resolution of these tiny lesions. Comparison, this is a comparison to a high resolution in that right coronary we just saw to what it looks like on the standard scanner. The brightness is much, much lower here than it is here. Here's the left main, that tiny piece of calcium here, what it looked like on the standard scanner versus what it looks like on this. You can see the background noise is higher because the number of photons per detector is lower. And so you're going to get more variation in each one of these pixels. But the peak signal of this calcium is higher than in here. And this is fantastic. This is like a 2x2, so it's probably a 1 millimeter piece of calcium on the high resolution scanner. And this is what it looked like on the standard scanner. Barely able to make it out. Probably would not trigger a positive call using the standard coronary calcium algorithm. Coronary calcium detection is a very important application for cardiac CT. And this is an example of that, where you see on the right panel here, these are 3 different patients, patient 1, 2, and 3. They all have exactly the same clinical risk for having a heart attack. And that clinical risk is computed through the Framingham risk score, which has been around for a long time. The Framingham study has been around for a long time. And so each one of these has equal risk by the Framingham risk score. However, this patient has absolutely no calcium detected in their coronaries. This patient has some of these small pieces, giving them a CAC scan score of 100. And this patient has considerable calcium in all of these vessels and a CAC scan of 400. So the question is, which one of these people do you think is more likely to have a heart attack? Well, it turns out it's this person, the person that has more CAC. That's not that surprising, given the fact that they've demonstrated they make lesions and heal them and build up calcium. And when you compare the predictive power of coronary calcium imaging in patients that are sort of in the mid-range of risk, so if you look at their Framingham risk score and they're below 20%, i.e. they're not super high risk people already, and they're above 5%, i.e. they're not zero risk from the Framingham score, and you ask what happens when you add the coronary calcium score to that Framingham risk score, the ROC goes from this dark blue curve here for the Framingham risk score alone to this orange curve with Framingham plus calcium. And you can see where you can operate on this curve depending on what threshold you put on the CAC score to say or make a positive call that someone will have an event within the next 7.5 years. If you use calcium 100, you're going to pick up 80% of the people who have heart attacks you will have predicted correctly, but you'll also get a fairly high 35% false positive rate, right? Somewhere between 100 and 400, you can pick up about 65% and have your false positives quite low. But the real point here is that it's so much better than the Framingham risk score. Not only that, it's so much better than the Framingham risk score, plus all of the new modern methods for predicting, risk for coronary artery disease. And you can see them down here: flow mediated dilation, intima medial thickness measured with ultrasound, ankle brachial index, C-reactive protein measurements. All of these things have many papers written about them, but this is their fundamental performance in the MESA cohort. So calcium kind of wins the day on all this stuff. And so it's a sensible test. It's very low dose. There's no contrast injected. You don't even have to take your shirt off. You just jump in the scanner. You can do it in 5 minutes, and it costs about $100. The problem with that is nobody makes any money, so. Having a high calcium score has been shown over and over again to predict having events. And so the red bars here are the number of events in this group, say, that has a calcium score. This is on the log scale of 5.5 or something. Oh, sorry. About, yeah, 5.5. And so the ratio of the people with events to non-events with that calcium score is much higher than, say, when you have a lower calcium score. Now, as you can see, if you have a really high calcium score, it doesn't mean you're absolutely for sure going to have an event, right? You've got a 2/3 chance of not having an event, but you are at much higher risk than the basic population that has no calcium down here. One thing that has been fixed about CT in the heart over the last few years is the fact that we can do the entire acquisition in a fraction of a heartbeat, so 160 milliseconds across some place. And even if the patient has a high heart rate, so here this patient, their heart rate is 89, 90. So that heart is humming along. In the old days, this would basically preclude a very good study with CT. But because now the study is obtained in this 160 millisecond window, you get really nice vascular images with these high heart rates. So that problem has been eliminated. For people who are quite slim, if their BMI is 27 or below, you also can get these studies done with very little radiation. You can use relatively low KV at 100, right? And a relatively low current or photon flux in order to get signal to noise that looks like this with a radiation dose that is 0.3 millisieverts. Now, remember back a few lectures, we said that radiation dose of 3 millisieverts is what you obtain just by walking around for a year as an alive human. So 0.3 millisieverts, you can't imagine that it modifies your cancer risk that much, given the fact that the baseline rate is 3 millisieverts. And this, to my opinion, this is just showing off, right? I'm not sure you need to go this low. If somebody performed a scan on me and it was this low, I'd say, you know what, why don't you just bump it up a bit and get better pictures? But we'll, it's still an open question. Two groups have looked at this for their projects, and it's one of the most important questions, I think, in medical imaging right now. These patients whose heartbeat changes as time goes on. So here, this delay here would give you a heart rate of 71, and this very long delay gives you a heart rate of 32, and they're back-to-back beats there. These are back-to-back. And so when you needed multiple heartbeats to make a single picture, this kind of behavior precluded making good pictures. It does preclude making good pictures with magnetic resonance unless you do some clever gating. And you can imagine this also screws up SPECT, PET, anything else that requires multiple beats. But now that we're down to one heartbeat, you can just wait and trigger on any one of these and take all of your data in 160 milliseconds and you're okay. And then you get a picture of a vessel that looks darn good, right? Patients who have this high variability, they're usually in atrial fibrillation. And the interesting thing about atrial fibrillation is the atrium itself doesn't really move that much, right? So it stays in kind of a fixed position. It inflates a bit, and when the ventricle fills, it drops in volume. But for many of these patients, the heart is pretty stationary up at the atrial level. So what we're going to talk about now is a thing called fractional flow reserve, and this is a big topic. I'm going to pause the video for a sec to make sure that the recording is okay, and I will be right back.